And so we'll start in about 30 seconds. Okay, so if you're needing to change your name, now what I do is when I look at my square to the right, if you go up toward that, just put your cursor over the square toward the right, three dots pop up. The right, it says mute, unmute, and then three dots. If you click the three dots, a menu pops out. Let me click it. And then one of the options is rename. And then if you click rename, you're able to go in and change your name. So yes, so you on the square, there's three dots. And let me cancel that part. And so that's how you're able to change your name. You do want to make sure that your first and your last name is correct how it appears on the roster. Remember, these sessions are recorded and they're reviewed by the attendance administrators, and we don't any confusion about whether or not you were here. So if you're undergoing a name change and it has not officially occurred, just put whatever it is, how you're listed on the roster. We'll give you about 30 more seconds to do that part. All right. Well, good evening and welcome to week 4. Give everybody a chance to get it in there. So if you go to that square, and that's my view, your view might be a little different. It may be a different way to change your name, but that's just how I see it. Okay. So welcome to week 4. Now, remember, I said week 1, once you all take those first exams, to me, I know it's the same time, but it seems like, after that first exam, especially if you're taking more than one class, you're having clinical, you have family responsibilities, you have all these things. And so at some point, you do need to pause for a moment, look at everything, step back, look at all your responsibilities and, rearrange what you can, delete what you can, put some things on pause because, we're after that first exam, we're almost halfway. And especially you all, you're pretty much, toward the end of, your studies here. So just look at that and rearrange some things if you can. I don't know if you all have to make a clinical. I don't know. Everybody's situation is different, but we looking at what you need to get done prior to, week 10. Be looking at all of those things so you can get all that stuff marked off your list and getting it done. All right. And so we have this week, we have new concepts this week and next week. And then we have our exam 2 will be, this is for 4 5, so week 6. Let me go to the course room here.
Dr. Norton, question. Are
Mhm.
you able to see our exams before we take them?
Before you take them, we go in and set up the date and time, if that's what you mean.
Oh, so you don't see the questions or what we're actually being tested on?
I don't generally look at it. Why do you
Oh,
ask?
okay. Just a general question.
Yeah. So just to keep it unbiased, so they're saying that we're not teaching to the test. I mean, we teach the concepts. And that's why I say no matter how, if you know to understand the concept and you're able to apply it, then no matter how you see it, you should be okay with it. Just like even for what's the other test you'll take at the end, like the HESI, we see like the concept. So we'll be like, okay, everybody say delegation is big and things like that, but the actual questions, we don't do anything with that. Um, but as far as knowing the concepts, like let me share my screen here. For week 4, we're talking about communication. And while we're thinking communication is a small topic, but just think about patient care. How many moving parts is it to this patient coming into a facility, receiving the care that they need, getting discharged, understanding what to do at discharge. But then think about if they have to have tests done while they're in that facility. Think about all the people on the healthcare team with this client's discharged home. What do they need to know in order to manage at home? What if this client's going to a long-term care facility? What if their insurance doesn't cover this. What if they need Meals on Wheels? So communication, it seems like a small topic, but when we break it all down, if we really understand, all the different moving parts of communication, no matter how it's presented to us, we'll be able to, select the correct response. Looking at assertive communication, aggressive communication, being passive. So we have communication for this week and assertiveness. And then we're looking at those that are on the healthcare team. Let's see. And then we have next week, we'll look at leadership in that collaboration. And so the main topics what I'm looking at is leadership, collaboration, and then communication and those on the healthcare team, which all of them really goes back that even that leadership, it goes back to that communication piece. So then we review information this week and next week. And then exam 2 is week 6. And then for sure really next week we're halfway because even though we have 12 weeks, that last week is just for remediation and we just meet really for attendance. So next week we're really like halfway. So make sure that you're looking at everything and rearranging, deleting, whatever, that's specific for you. All right. So we pretty much probably will just use our chats this week for your responses. So just make sure that you're responding in the chat when we're asked you to. Let's see here. Let's look at our information here. So we'll try to, if we can, have time to get in your week 10 group, to meet briefly if we can, but we want to make sure we get through all of our content. And then we'll look at a case study and then we'll go over our PowerPoints just to make sure we cover all of our content because we have this week and next week. So let's see here. We will start with which one is let's see. Let's just start off with this chapter 8 communication. So the first slide says, I'm going to share my screen, discuss care coordination. What does that mean to you? In the chat, want to utilize the chat. We'll give you enough time to think it through. Discuss care coordination. Like think about those two words. What is care and what is let me just go back to the group project. We're saying WhatsApp video. How can we start a WhatsApp video? I'm not sure what that means, but your final project is a PowerPoint. Now, if you all want to communicate through all these different means, that's fine. That's up to you all. But
Yeah, I think that's what she was saying. Sorry. We didn't know it went sent to like the entire group chat. We thought it was, yeah, just
yes,
ignore it.
that's
Sorry.
how it is. So yeah, it with the updates on Zoom, you have to specifically click all these buttons to go in to pick who you want to talk to. It wasn't like
Yeah,
that at first before the
I
update.
did.
I'm seeing that now. But Tiffany, I'm going to email you, okay?
Okay, no problem. I clicked on their name. I don't know why. I'm sorry about that, Dr. Ford.
Oh, that's fine. But just so that you know, it does, and that's why I say before the test, before the exam, make sure you find our name and send it to us because otherwise it goes to everyone. Before the update with Zoom, it didn't used to do that, but anywho, that's fine. So discuss care coordination. Remember, we're talking about communication. We're talking about those that are on the healthcare team. We're talking about what we said, leadership. And what was the other thing that we said? Leadership. Okay. And I think those are big topics. Collaboration, leadership, communication, and those on the healthcare team. So considering those 4 pieces in the chat, I'm gonna give you 2 minutes and get my little timer out here. What would you say care coordination is? And remember, we're talking about, we're dialing it back. That middle person is the patient. The resident, depends on what setting you in, is what you call them, but that person that's receiving that care. What does care coordination have to do with anything? And think about all those main parts. So let me get to my timer here. For y'all, the 2 minutes be up before I start the thing. Okay. So care coordination. If you were explaining to someone or if you were trying to sift through a scenario, what are those things that you need to consider? As you are, getting ready to decide on which settings you're going to go in. a lot of those settings, you're going to be that team leader. You're going to be that person that's in charge. And what that means is when it depends on that setting, once that person comes in to receive that care, you're going to be the one that's going to be saying, hey, this, and this. Because remember, that nurse is going to be in that middle. You know, even though we have the healthcare provider, the speech therapist, we have the dietitian, the family, that nurse is right there. So what is this care coordination? What does it mean? How are we going to, we got 1 minute, 12 seconds. Let me look at your responses here. So discussing a plan of care with the people that are involved. Strategy, care coordination is an organization of activities that share information with everyone involved. So yeah, the nurse is going to be, you're going to be that person. They're going to be coming to now how often we need to turn this person? Now, where is that care plan at? And you're going to be referring them to that care plan. But right at that moment, they're wanting that response. And so you're going to have to direct it to the care plan. And also maybe that unlicensed personnel may need help interpreting their care plan. Well, it says you need someone to assist you when you go in to turn and reposition this person. Care coordination means making sure all your doctors and healthcare services work together and share information so the patient get the right care without confusion or mistakes. And that's exactly what one of our slides say that we'll go over here shortly. And so think about the number of people. We've heard commercials. We may have experienced it ourselves or family members that have to be readmitted or left the pharmacy with this medication. They didn't even know what it was, really when to take it. I think prescriptions now, our time is up, or 2 minutes is up, where they're actually writing out twice a day, one in the morning and one in the evening, actually writing this stuff out, because I think we take for granted that lay people know the same things and have the same understanding as we actually do as healthcare providers. So good definitions. So you would take that definition, your understanding, and then you would apply it to situations that you're being presented with. All right, let's see. Okay. So care coordination is recognized as a professional standard, and it's essential. It's essential that we understand. For example, I think I gave the example a couple of weeks back where the patient where it was in a long-term care facility, or they could have been at home, and they had an appointment with a specialist or a follow-up appointment. But at the same time, physical therapy might have been coming to the home, or if they were in a long-term care facility, physical therapy was coming to the room to get them to take them to the therapy room. Patient was not there because they went out of the facility for the specialist appointment. So what does physical therapy do? Does this patient not get their physical therapy because they went to the specialist or the follow-up appointment? We have to coordinate that so that the patient gets all of the care, everything that is listed for them to get. Care coordination is fundamental in improving the quality of care delivery, like the example I just gave, while reducing inappropriate use of healthcare services. We have the physical therapy coming to provide the PT for the patient, but then the patient isn't there. This patient may have just had a stroke, hip repair, hip surgery, broken arm or leg, and they're needing to get back into the movement of things. So that's a whole session that they're more than likely going to miss. So that's inappropriate use of healthcare services, because what happens is that therapist is going to document this patient is not available. And then if you're that nurse or that person that's, I forget what they call them, on the insurance side, because as a nurse, you can work on that insurance side, and they look at what's documented, and they say, well, this patient is not available for these services. They must don't need these services. And so we do want to make our patient aware of that. So we want to coordinate things so they don't miss the physical therapy, and so they don't miss their specialist appointment. And also, we do want to support our clients when they make a decision, but we do want them to make informed decisions. If patients are refusing physical therapy, speech therapy, and those things, they have to document that. The insurance companies look at that and say, well, hey, this person don't want these services. And what they'll do is they'll stop the service. And a lot of times, if they are receiving, the people are coming to their home, or if they're in a long-term care facility, that skill is why they are there. That's what's paying really for them to be there. So if they're no longer receiving the skill of the physical therapy and all of this, then that person is soon to be discharged because they're not going to want to pay out of pocket to stay in that facility. So while we will support them in whatever decision they make, we want them to make informed decisions. So we don't want to be using healthcare delivery inappropriately. And on the other side, where sometimes you see that sometimes if a person goes from a healthcare provider to a specialist, they will repeat tests. I just had those blood drawn. You're drawing the same test. I just had that MRI done. It's the same MRI. And so if it was in a certain time frame, it's inappropriate to have those things redone. But if it's out of that time frame, I think it's like 30 days or whatever, then it is appropriate. So that's another example of inappropriate use of healthcare services. But care coordination decreases or lessens the chance of that happening. And it goes back to what? Communication. Care coordination organizes care and information around the patient's needs and preferences. So make sure that you understand that this care coordination. It seems something like simple, but it goes back to effective communication. Care coordination is one of the 6 priorities identified by the National Quality Strategy for providing more affordable, improved, and patient-centered care. And then, I think we talked about this in what class was it? Those DRGs where they have the insurance company pays. For example, if you're going in and you have a broken arm, fractured arm, they only pay so much based on that diagnosis. And so you do want to make sure things are coordinated. So, because they only give you so much, the other piece of that is so much money. The other piece of that is making sure we document everything, because while the DRGs have this set price that they'll refund or reimburse the facilities for, not everyone that has a broken arm, the person that has a broken arm might also have hypertension or diabetes that we also need to manage. So that's why it's important to make sure that we're documenting so we can provide that unique patient-centered care. And then with hopes of decreasing the cost to the patient. The Patient Protection and Affordability Care Act identifies care coordination as keys to shifting towards value-based care delivery models. They do have, now this is not the main task of the nurse, but in a lot of facilities, mostly the hospital settings, acute care settings, one of the tasks of the nurse would be to come and ask. They either can ask verbally, they may have a survey on paper, they may have an electronic survey, where they'll bring it to the patient, and they'll ask the patient questions like, hey, did your staff speak? Were they nice? Did they wash their hands? Did you see their name tag? How do you feel about the care that you received? You think it was timely? They'll ask all these questions. And it's all incorporated into this reimbursement. So that's another task that you may not have seen while you've been in those settings, but that's an additional task as a nurse that you could actually do. And it all goes back to, it's not that they're trying to tell on anybody, but just making sure that we're providing that best care we can for our clients. And then if there is a discrepancy in understanding, that we provide that information in that person's primary language that they can understand and on a level that they can understand. If I need pictures, if I need an interpreter, if I need this translated to German, if I need it translated to English or whatever, so that I can understand and make an informed decision. So effective care coordination helps prevent fragmented services, just like we just explained, cost inefficiencies, and poor health outcomes. Because just think about it. If the patient goes to the specialist, but then they miss their physical therapy appointment, and if they're refusing physical therapy, and they don't really understand that at some point that service is going to be cut off, and that they need that service to get them back moving like they're supposed to, up and just as things that we don't even think about. Just think about what movements and motions it takes to open a door, to take the trash out, to actually crack an egg and put your pot on the stove, or to open a refrigerator. So we do want to make sure that the patient does understand all this, because we don't want them to have poor health outcomes. And if it's the difference between just me understanding, oh, I really need to go down into physical therapy, but I'm in pain. Well, we need to communicate that with the healthcare provider. If the patient doesn't have something ordered for pain, then we would need to communicate that. More than likely, the healthcare provider will order something, and it's usually going to be administered prior to physical therapy so that they can endure, because it is painful. For example, if someone's had surgery, someone's cut on someone, and they have new joints and things, and so over time, it's going to take the body time to get adjusted to that. And so they're going to need that pain medication. So when they go to therapy, they can actually comply and do what is needed. Okay, so I have is a scenario up here, and I think let me stop sharing. I think I have some questions after this one. So I think I want to just show you the scenario and give you some time to. Okay, so this is what we're going to do for this. So this slide, I'm going to show it to you, let you read through it. We'll give you about 4 minutes to read through it. And then just on your paper, just do some jot noting, things that come to mind. I'm not asking these specific questions right now. I'm going to ask the specific questions in just a moment. Let me move this little bar out the way. So just read through and then just do some jot noting, some things that just pop in your head, good, bad, ugly. And then let me give you 3 minutes to be enough to read through this and do some jot noting. And then we'll look at some questions here in a minute. Okay. Just read through this scenario. Okay, 1 minute, 32 seconds. Okay. So my question to you is, and come off mute, one person speak at a time. Are there any examples of ineffective? Well, first of all, someone give me a definition of ineffective communication. Define ineffective communication.
I guess communicating, to a person that, they're communicating, they don't understand, they're not understanding the task or the questions that you're asking or what you're saying. I don't know.
Okay. Anyone else? Ineffective communication. Ineffective.
Like using such as what's the word I'm trying to like vague wording or failing. Basically, she wasn't listening to the patient, or I guess ignoring messages or signs of what was going on.
Well, I
So not
said
specific,
that
not
she
not
couldn't
with
understand the
hold on, Miss
person.
Raiden. Listen.
Okay.
So first off, my question, not talking about the scenario, I'm asking you what's a definition of
Oh.
ineffective communication. We're going
Poor
somewhere. We're
communication.
gonna get to the scenario. Okay.
So poor communication and poor listening is what I was
Okay.
saying.
So on the flip side, give me a definition of effective communication. You're trying to explain to someone what effective communication is.
Understanding.
Understanding.
Okay. Okay. Good, good, good. Okay. And so what's another term that we can use for ineffective or effective? What's some other terms that you all are used to saying? Barriers to communication, that would be ineffective. And
Poor
then
communication.
say that again, Ms. Burns.
I said poor communication.
Poor communication. Okay. All right. So as you're reading through, we're doing a test taking thing too. I know we're getting ready to talk about this little scenario here, but as you're reading through, tomato, we all just said the same thing. Poor communication, ineffective communication, barriers to communication. And so no matter how we word those three things that we're asking for those examples, they all mean the same thing. And on the flip side, we said effective communication. Communication was being facilitated. Okay, so you got your notes from your scenario here. All right, let's go over to some specific questions. Here we go. Let me say this before we answer the question. So communication does have two parts, a receiver and a sender. And so something's being communicated from the sender, and hopefully the receiver interprets it as the intent that it was sent. Okay. So now let's talk back. Let's look at this scenario here. We have Maria. What was the nurse name? Maria was the patient and assigned to Maria. Maria and Jamie.
Yeah. Jamie.
Maria is the patient and Jamie's the nurse. Okay. So number one, what communication barriers were present?
She only spoke
the same
Spanish,
English. Yeah.
and she only understands a little bit of English.
She had her daughter.
And her daughter wasn't there to help translate it in the morning time. Normally she do.
First of
So
all,
we
Jamie
have
wasn't listening. She knew that she didn't speak English well, so she should have
Yeah.
brought an interpreter with her to start with.
Mm-hmm.
Or the
even
RN should
though
have let
Miss
Jamie
Clark,
know.
Miss Clark, what about the family piece? So should we have an interpreter, even though
Yes.
even if the family was there?
Yes,
Even
because you
if
don't know
the
what
family
they're
was there,
saying.
because
Yeah,
sometimes
exactly.
they don't
Good.
explain it the way that it's said. So you should have had an interpreter there.
Anyways, exactly. It's good
Yes.
to have the family there, but you all remember we're in this legal setting, and so we do want that. That's why that person's there, that interpreter, regardless of the family members. It's good that they're there. They have the support, but we want that interpreter. Okay, good. So what are the barriers? You said it wasn't in the person's primary language. What else?
She didn't listen. Or try to understand that
To
lady was pointing at
cues.
her.
She didn't assess more.
Yeah,
she
she
didn't
didn't say
assess
some
her.
more.
She just came in like she was in a hurry. Let me hurry up and give her this medicine.
Okay.
Yeah, it looked like she was rushing.
In my thing, I was just wondering, how did she even verify? So when we go in, we knock on the door, we wait that pause, or it's we wait until the person tells us to come in on the other end. We identify ourselves and our purpose, and then we verify who the person is. Did she even verify who this patient was? She was trying to get this medicine to.
No.
This is just a whole. This is
didn't.
really not a good situation here, and unfortunately,
It's a
this
lawsuit.
probably does happen. What you were saying?
So it's a lawsuit.
Exactly. So those principles that are in place, it may seem like we're wasting time by verifying who we have, going through our medication administration rights. These things are in place to protect the patient as well as the nurse. So, okay. So any other barriers? Any other barriers that you all come up with? Okay. So next question. What cues suggested that Maria may not have understood the LPN's communication?
She touching her chest.
Okay.
Nodding her head, like,
And she looked
looking
confused.
confused.
Okay.
But she said she's not confused, but nods her head. So
Okay.
Here.
So we talked too about making sure that we are not only writing and documenting verbal responses, but if we want to pay attention to those nonverbal cues as well. And we document both of those. Even if they're conflicting, we need to write them both down. In this instance, this is just a whole mess up here. And so the patient's confused, doesn't even know what's going on. And something I even thought about too, if she went ahead and gave this patient this medication, it's just scary. This situation is just scary. It's just not good. Okay. So what should the LPN have done when Maria appeared confused?
Got an interpreter, and so she can assess her,
Mm-hmm.
and,
She
and
should
Yeah.
have
try to
stopped
Yeah,
what
understand
she
she
what
was
should
she's
have definitely
saying.
doing.
got an interpreter.
I
And
heard someone say stop. She should have
She
just
should have
stopped in her
stopped
tracks
yeah,
her.
just stop and I say the charge nurse as well.
Yeah,
and
she should have went
refocused
back and got
herself.
that RN
Even before
because
then,
yeah,
this nurse has their own license. They've been through the whatever school they've been through. They went through simulation lab. We went through skills checkoff. You went to clinicals. You had
Check her
precepts,
vitals.
mentorship. What part of this do we? I didn't even see she knocked on
Check
the door.
her
I don't see where
vitals.
she even verified who this person was. She
Mhm.
needed to put herself on pause and say, I am messing up here. I
Right.
need to stop. Because it's so many things that she just didn't do.
yeah, she
Okay.
just seemed like she was just hurrying. I want to
Exactly.
get this done quickly. I wanted to get this done quickly.
Mm-hmm. Exactly. So why is it important to use a certified interpreter instead of family members when possible? I think someone mentioned it. So why is
Because
that?
you don't know what the family member's interpreting to them because you
Yeah,
can't understand it. So
Mm-hmm.
you want to make sure they're getting the correct information.
And the
Exactly.
family may
exactly.
have a bias. The interpreter
Exactly.
wouldn't have a bias.
Exactly. So how could therapeutic communication have improved the patient outcome?
Well,
If
she
you
would have
would
knew to
Could have
start
got
with that the patient
could have
was in
got
some
help.
some discomfort already.
Right.
She would have got that information first instead of, trying to rush and go ahead and give her the medicine and all that. She would have got that information and could have assessed her sooner instead of, waiting
mm,
until the RN comes in like 30 minutes later. It could have
And
been a whole nother situation. She could have been like in a serious situation with the chest pain and all this dizziness that was going on. She could have been, on the road to a cardiac arrest or something.
and then you
Okay.
never want your patient to be confused on top of not feeling well as well. You want them to, understand what's going on with them. So I think that's a big part too.
Okay. And so this nonverbal cue of this patient pointing to their chest and say something in Spanish. Jamie assumes she's referring to her pneumonia and continuous medication administration. Still, this person, they've been there, and even if it was pneumonia, that it wasn't just outright chest pain. Still, at that moment, let me just stop and reassess and let's see, do I need to reassess vital signs? Do I need to ask a more focused question about, what side of your chest? Does it hurt? What does it feel like? When did it start? I mean, all is just like I said, this is just a bad situation here. Just a bad situation. Then she has hypertension. So who's to say that it's pneumonia versus this person's really having chest pain? You just never know. And then come to find out this person really is experiencing new chest pressure and dizziness for 30 minutes. That's a long time, long time, long time. Okay, good. So, factors that affect communication: personal characteristics, we have cultural characteristics, situational influences, and then context, background, and circumstances that lead to the conversation. So, all these things affect communication, especially if your patients are in, for the most part, facilities now. They try to, if they can, only have that one patient in the room. But if they are having more than one in the room, and you're in working with, for example, patient in bed A, patient in bed B over there, they're in pain or they're doing a procedure. When you go in to assess and talk and interview your client in bed A, your person in bed A might be distracted. That situation itself may deter or prevent you from getting accurate information. So we do want to consider our surroundings, what is actually going on, because it can affect communication. And right here, it even says odors. So if we know that the patient, we're doing a dressing change, and this wound, may have some drainage, but for sure it has an odor, we know that we're getting ready to go in and do that dressing change. Facilities usually have some type of protocol, whether or not it's opening the window, whether or not it's using different fragrances on cotton balls and things like that to lessen that odor. And so that, we're not in frowning and making, doing nonverbal things that,
mhm.
that shows that we, are feeling some type of way about this wound smelling. So we want to make that patient, feel comfortable. So if we know that there's an odor, if we know that there are distractions, we want to get those things at a minimum if we can, lessen it if we can, because those things do affect communication. Okay. And you already kind of said it, that those nonverbal things. The patient was pointing to her chest, the facial grimacing, she was looking confused. We want to make those things are real. So even though it's not verbal, it's still part of communication. Okay. So what are some examples of nonverbal behaviors? In the chat, just drop one example of nonverbal in the chat. Just drop it in the chat. What's an example? Not necessarily in a scenario, but some things that we might think about your four senses. What's something that you might observe that is nonverbal, but it is information that you would need to document, either that you see it or it is not seen. Nonverbal behaviors. What's an example of a nonverbal behavior? Nonverbal. Let's see what we got. So yes, if you are needing to step away to use the restroom or something, just make sure you put a message in the chat. Don't forget that part. Nonverbal, like body language, facial grimacing. You can either document that you see facial grimacing or no facial grimacing seen. Moaning or no moaning noted. Shaking and trembling. Good. Hand movements. Scrunch eyes. Okay. All right. Okay. Facial expressions. I think you all have that. You all put gestures, body language, even yawning. Sometimes, just put that in there. If you're seeing things that are nonverbal, fidgeting, just write all those, just make note of those things. So there's a sender and a receiver. And we want to make sure that we are understanding what is being sent to us from the person, what is being communicated to us. So there are some techniques and some things that we can do to verify, to ensure that whatever the message that's being sent, that we don't misinterpret it as the receiver of that information. So we can restate things, repeating what the client said in a slightly different way, not changing what they're talking about. For example, if they're talking about, they're giving us a description of, we just keep it simple. They're telling us, they're describing an apple. And then when we repeat what they said, we're talking about a volleyball. Mm-hmm. So we're not changing when we're restating. And even if we're clarifying, we're not changing what they're talking about. So clarifying, asking questions in response to the client's statement to be sure we understood. So an example could be, let's see, ma'am or sir, you mentioned that it was, your stomach was hurting. So is it your right side or the left side? And then to ask them more focused, if they say right side, is it the right top or bottom, upper or lower, whichever words you want to use. Mm-hmm. And then that way you can get a more descriptive and be more specific. So reflecting, putting into words the information you receive from the client at an effective communication level, making sure that we are speaking, in layman's terms. We're not saying, BID, you take this medication, BID. They're like, I told you I take it. I told you I take it once a day or twice a day. Oh, so you take it BID or TID. Making sure that what we're saying that they can understand. Paraphrasing, expressing in your own words what you think the client means. Now, minimal encouraging, we use sounds and words to elicit the person to continue to talk. That could be hand movements, motion of our head up and down. And this one right here, we kind of struggle with. Just being silent, it is therapeutic, and it actually helps us to listen and hopefully not mix up the message that's being sent to us. But remaining silent, it is part of active listening. And then summarizing, you pull out those main points, because a lot of times, especially the patients, you've established that therapeutic relationship with them, and you ask about the abdominal pain, and they tell you about the abdominal pain. They tell you about the time that they went in and got their toenail removed, and they tell you about all these other things. And so you do have to go back and summarize those main points. And you said that your stomach was hurting. Now, I asked you, was it top or bottom? You pointed to the bottom, or you stayed at the bottom. You usually take, I don't know, Tylenol. You might take Pepto-Bismol, and you say that relieves your pain. And so that's just going back and stating those, pulling out those main points from what they said. Validating allows the client to correct information when we summarize. Okay, now I'm gonna go back over what you said. Now you tell me if the information that I'm, repeating to you is correct or incorrect. I need you to correct me if I'm stating something that's incorrect or wrong. And it gives them an opportunity to correct that. Because sometimes, like I said, the messages will get mixed up. The sender is sending it to the receiver, and as a receiver, we interpret it incorrectly. So, and we've already kind of mentioned open and closed questions, communication. Close, you're getting those specific question answers. Yes, no, is it the top or bottom? And they'll say top or bottom. And then focus questions where we will go in and, well, what makes the pain get worse? Do you do anything that makes the pain go away? What have you done in the past? And that's that narrowing down. If they answer yes to something, then usually we jump to that more focused question to find out more information. And then that more focused question too will also allow you to determine whether or not this client really understood what they said yes to, because sometimes there's that misinterpretation. So here we go. Positive communication, you all. Using iMessages, that's therapeutic. Rather than saying you, if we're using I, that furthers facilitates communication. And we want to be aware of our body language, making sure, we're making eye contact, not sustained eye contact, but we make eye contact, we may look away and not glaring eyes as though we're being aggressive. And especially when we're doing the dressing change, make sure that we're not in there, making sounds. Our face, we have facial grimacing and things ourselves. So just be aware of our body language. All right. Attentive listening, empathy, and developing trust will facilitate effective communication. So establishing those therapeutic relationships, being silent, restating, asking them to correct you, validate. I'm gonna, I heard what you just said. I want to go back over. I'm gonna pull out these main points. Now I want you to correct me if I state something that's incorrect. So that's that active listening, and it further develop that trust, and it shows that you're really interested in taking part in their care. It shows that you have their best interests at heart. Assertive communication. We'll talk a little bit more about assertive, aggressive, and passive on our other set of slides. But assertive communication involves expressing ideas and opinions openly while remaining respectful to others. We're not bending rules. We're just being honest. We want to make sure that we are actually, making sure, be aware of our surroundings when we're talking to people. If there's a passerby there, we might want to take that patient to a room that's private, because then, that's not being respectful to that person. So assertive is being honest, expressing ideas openly, honestly, and then being respectful to that person. So, and that includes making sure that things are private if we're discussing things that need to be private. Using those I statements to express one's thoughts, feelings, and needs clearly and directly. If you ask the leader, the unlicensed personnel come and ask, well, hey, how many people do I need to turn and reposition this person? It's expected that you have assistance. This person needs 2 persons assistance. It's expected that it be turned every 2 hours, and that starts at noon. The next time should be 2 p.m. That information is honest, it's clear, it's being respectful. This approach allows for honest expressions without blaming or attacking others, promoting effective interpersonal communication. Now, I'm going to repeat these main ideas from what you said. Now, you correct me if something that I state is incorrect. That further promotes that effective communication with you and that patient, as well as the members on the team. So we talked about positive communication, and we have the opposite, negative. So this one, all of these right here, we pretty much know about, but just giving advice. Because you're that person, you're that trusted individual, you're that nurse. The patients, and they don't mean any harm by it, but a lot of times they want to, nurse, what would you do? And in this instance, we don't want to give our opinion. We want to make sure that this client, we want to reassure them, hey, if you need more information, I'll add a scenario. Patient, the doctor just came in and the patient signed off on a consent, or they said that they would go ahead with the procedure. You come in and the patient says, hey, I just told the doctor I would go ahead and, have that procedure done, but I'm really not sure about it. Nurse, what would you do? So in that instance, we want to, get some clarity. What questions that they still have about the procedure? Notify the physician. Or if it was a dietitian, they came in and went over, the diet plans for that patient. And the patient said, hey, I just went ahead and just said, mm-hmm. So whatever that person said, we'll bring that dietitian back in. So this patient can make an informed decision. And at the same time, let the patient know, we're going to support you, but I want to make sure that you have all the information that you need, but we don't want to give them advice. We don't want to give them advice. Okay, that's good. So yes, if you have to log off and log back in, because I know weather is moving through different places, so that connectivity may be an issue. A lot of times you may have to log off and log back on. Just drop a note in the chat and then make sure you try to log back in. If I lose you all, y'all just stay right there. I'm gonna log back in on a different device. Got to tell you all that because I know weather is moving. Some stormy weather is going through different places. And just communication. And it's just an ongoing process. It never ends. Like I said, that communication it's just one word, but it's a huge piece. Okay. So the Institutes of Medicine, they created this tool that we use so that our communication, that we don't forget anything, that is structured and it's like clear and to the point. This thing called the SBAR. Situation, background, assessment, and recommendation, which is good. So we use the SBAR, to communicate. Either we're handing off, and we're going to talk about that one. We're changing shift. You're going home and I'm coming on. And or we're calling the healthcare provider for whatever that reason is, that situation. What is the reason that we're calling? It could be that we receive lab results. It could be that the patient's complaining of pain. They just received their pain medication an hour ago and it's not time for the next dose. It could be that, the patient, like I said, changed their mind about the procedure that they're scheduled for in the morning. What is the reason that we're calling? We want to include our name, the unit, the client's name, and the problem. What is going on? Why are we calling? What's the situation? We want to give that background, their code status, admitting diagnosis, the date of admission. And facilities pretty much have this on some type of little sheet or some format so that you can remember when you're calling. Usually they'll have it by the phone or as a part of your onboarding package. And then an assessment. What do you think is going on based on the data findings? Because remember, we're spending most of the time with the patient anyways. Healthcare provider, they come in and out, but the nurse, we're there with that patient. So they value our input. They want to know, what do we think? What are those findings? We do want to, let me go back up to this vital signs right here. You want to get the latest vital signs. If we're calling at 1 p.m. and, we've been on shift since 7, we don't want to get those 7 o'clock vital signs. We want to go ahead and get an up-to-date set of vital signs also. So this assessment, what do you think is going on based on the data findings? And it's whatever you think. An example could be, when I came on shift, I got a report from the outgoing nurse. They said the patient was oriented ×3. They knew who they were, the purpose of being here, and they knew the time. As shift has went along, the person can only tell me who they are. They've had a mental status change. Now, what is some other information? The vital signs, where I did notice that the blood pressure was this. Now I've noticed they have a cough. I did not receive information in shift report or when I first went into assessment, they didn't have a cough. Now I notice they do have a cough. So what do you think is going on based on your data, your head to toe assessment, all that information that you have gathered? Is this life-threatening or not? And then recommendations, goals of care, what needs to be done, including consult, medication orders, or transfer. So when we're doing shift report, it's almost the same information, but our situation is we're going home and someone else is coming, or vice versa. And so as we have documented during the shift, for the most part, facilities have, as part of their electronic health records, they create these cardexes. They go in and pre-populate what they want. So it's printed or either it shows on a screen. So this information that you put in throughout the shift is going to be there. It's going to have your latest set of vital signs as you're exchanging shift, as you're handing off the patient to the next person. So consider the age of your person. If you're that school nurse and your patients are, children or, young adults, adolescents, we want to consider the age, because the way we may say it, we might need a parent or guardian there. Our explanation might be kind of different. We're not changing what the explanation is, but the delivery of the words that we might use more than likely will be a little bit different. So consider who you are talking to, the age of them. So when charting, making sure that you're charting factual things, not appears. What did you see? It was round, drainage, no drainage, raised, blood pressure. What was those measurements that you saw when you heard the boom boom? Did you hear abnormal breath sounds? What did they sound like? So we don't do it appears that they're hurting. No, state they had facial grimacing. They rated pain as 5. So making sure that our information is accurate and factual. So, we use all different types of communication, things to communicate. Inside the facilities, we have the call light. You have some facilities even have like these, they're cell phones, but they're not cell phones, but they're all different types of communication. So conflict resolution. So the ethics committee, this is another task that you can actually complete within whatever setting you're working in. For the most part, all facilities have them in the different settings, like ethics committee. And what usually happens is if the conflict cannot be resolved, it goes to that ethics committee anyways to resolve. Conflict is just a natural part of life. And so a patient can have a complaint, or it can be real, it can be valid, and it cannot be valid. But nevertheless, that sometimes there's conflict and things that come up that have to be worked through. And so let me just read through this. Accept conflict is a natural part of life. Temper your attitude and behaviors. Be aware of your initial reaction and take a deep breath. Take time to critically think before reacting. Treat conflict as an opportunity to voice your own opinions and listen to the other side of the story. You want to choose your approach. A win-lose approach will only escalate the and intensify the feelings of those involved. A lot of times when conflict comes up, it's just a misunderstanding. Something hasn't been communicated, or what has been communicated was not received correctly. We as a sender may have went in and did something or said something, and the person that received that information, it was misinterpreted. And then you wanted to listen and learn. Conflicts are often based on assumptions and lack of information. They assume, and then discover what is important, the core issue. A lot of times when you step back and get statements, you have people to write things down, or if you rewind the video, then you look and say, well, wait a minute, this is not really what they're even talking about. If they have to write it down, or if they have to give their statement more than one time and people go in and write down what they're saying, a lot of times the issue is what they initially stated really isn't an issue. It's a lot of times something else, and usually just a misunderstanding. But nevertheless, you do have that ethics committee, which we have a slide here somewhere on it. I thought it was the next one, that will look at the conflict and resolve it. Because what facilities want, they want improved satisfaction from the team members. They don't want their staff to leave. They want their patients to keep coming back. And so it's an opportunity for that organization to grow, to revise things if they need to be revised. And that conflict resolution, it helps hash that out to determine, hey, our process said we need to do this a little different. So improved team member satisfaction is an advantage of interprofessional collaboration. Enhanced communication among team members is an advantage of interprofessional communication. Increased patient satisfaction with discharge transition process is an advantage of interprofessional collaboration. So we got improved team member satisfaction. Our staff, they're happy. Enhanced communication amongst the team members. People are communicating, even if there's a conflict or a problem, we can still talk through it, which means improve satisfaction amongst the team. And then as a result of that, our patients are satisfied. Even if they have outcomes that looks kind of scary, because they know that you're there and you have their best interest at heart, then they feel better. So then they have that, that satisfaction. They're more likely to return and keep coming back to your facility, and will recommend people to come to your facility. We talked about assertive. Uses the statement of facts and not judgments. Make sure that we're writing down the things that we actually observe. Appears, appears mad. Well, was their voice raised? So use those descriptive terms. They had furrowed eyebrows, the voice was raised, they were screaming. So write down what is factual. And then if we're communicating, like the example I gave earlier, I got ahead of myself. The unlicensed personnel came and asked, well, I looked at the care plan. What am I supposed to do for that patient in 201? We would be honest and respectful. That patient in room 201 needs to be turned at least every 2 hours. And then it goes from 8 a.m. to 10 a.m. to 12 noon. Complete the dress and change every shift. This is clear, open, respectful communication. And don't forget about that piece that I said, making sure that we are not violating the patient's rights or the rights of others, making sure that we're keeping things private. So that's an example of that. The ethics committee are an appropriate resource when other conflict resolution attempts have been unsuccessful. So hopefully that conflict can be resolved initially, but if not, that ethics committee. And like I said, this is something that you can ask on when you're sitting down for your interviews, ask about these other committees and see, and it might be of interest to you to work on. Okay, so we're going to stop here. Are there any questions before we take our first break? So this communication piece, it's a biggie. It's several moving parts, and we still have more to go. We're going to go ahead. We got 2 minutes. Let's go ahead and start our next PowerPoint. Just want to make sure we get through all of our content for this week. Let's see here. Do we want to do the healthcare team? Let's just go, since we started talking about assertive, let's just go ahead and finish assertive, but then we're going to look at the healthcare team. Let me share here. So assertive, we have non-assertive or passive. And then we have aggressive. So we want to be in this assertive piece right here. We're being honest, we're being open, we're communicating effectively, we're being respectful, we're not violating the rights of others or the patient. We're making sure that we're considering our surroundings. We want to make sure that we're keeping things private. If we have to take the person to the visitor's lounge or wherever that space is to keep things private, we don't want to just blurt things out and violate that patient's privacy. Aggressive, and we're going to have a scenario here later on, but we want to be aggressive is being disrespectful, is being rude. Why do you keep bringing that light? You just need to go ahead and take this medicine. And if you think about it, that first scenario we had with Maria, she was being aggressive. The patient, she didn't identify who the patient was. The patient was pointing. The patient looked confused and she didn't stop. She just went on. And then non-assertive, we're passing the buck. The patient, the example where I gave, the patient says, "Nurse, what would you do?" I just agree with whatever the doctor said. Well, if you agree, you disagree. No, we want to identify what information do they need, notify that healthcare provider, notify that dietitian. Hey, this patient said, they still have questions. And these are the questions that they told me that they still have. And but we don't just leave it at that. Well, you told them yes, you said yes to it, you consented to it. We don't leave it there. So we're going to pause here and we're going to take our first 5-minute break, and we're going to push our big break into the end, y'all, because we want to make sure that we go over all of our content. So return, it is 6:30. Let's return at 6:36. Remember, this video still records, so make sure your cameras are off and make sure you're on mute. We'll see you at 6:36. All righty. Hopefully we're able to get a little movement in. Let's move forward here. Let me share my screen. We're still talking about that communication. Let's see, share screen. But now we're being a little bit more specific. We're talking about assertive communication and aggressive. They're like the opposites. One's respectful, open, honest, and the other one is disrespectful, rude, not being honest. And then the pass is in the middle. We're just kind of passing the buck. We're not really we're not addressing whatever the issue is at hand. Okay. So, and really non-assertive passing the buck, it really is a part of being, dishonest because like even if like the example that I gave, we need to notify that healthcare provider that this patient still have some questions, and they just stated, they just agreed with you because, you were going so fast and they thought this they were supposed to do, that it's really, if we don't notify that healthcare provider, the dietitian or whomever, it's really a way of being dishonest because we know that that client really have not made an informed decision. Okay. So aggressive violates the rights of others. And remember, it is, being rude, not providing that privacy, putting all that patient's private information out there. And it's attack on the person rather than the behavior. And then want to be considerate of our body language. If you're being aggressive, we're leaning forward, those glaring eyes, our voices may be raised. So it's like the opposite of assertive. Okay. Assertive, we're being honest, we're talking, we're being positive, with a positive stance, being confident in the statement. Yes, this patient needs to be turned every 2 hours and it's on even hours. For example, 8 a.m., 10 a.m., 12 noon. You do need two persons assistance for that. The dressing change should be done every shift. We're given this specific instructions and we are not, we're just, being open and honest with what is expected. We're maintaining that eye contact. We're not using glaring eyes. We're making that eye contact. And we're being open and honest. We are using statements of facts, not judgments. It appears. So what is the facts? This person has facial grimacing. They rate their pain as a 0, but they're guarding. They're crying. They're moaning. They're doubled over in pain. And so this is just an examples of being assertive. The UAP came and asked, well, how often do we do vital signs? They should be obtained daily. So we'll just get them. They got them on day shift. So that will be the daily. Just giving that information. Measure the weight monthly. These are just some examples of instructions and things that we're going to be being asked as that nurse that's leading that team. They're going to come and ask you that. Assertive communication needs to follow the chain of command. Unless, and we'll talk about the chain of command on next week, but we need to follow the chain of command unless there is some type of imminent danger or some type of issue that needs to be addressed immediately. This is not talking about if it's an emergency. So we want to follow that chain of command. Someone mentioned early on getting that situation where the team leader came in, the RN came in, we will notify them. Maintaining client safety. And then we're advocating for that client, maintaining that client safety, considering, the surroundings. This patient, they keep getting up, without being assisted. They're confused. They're at risk for falling and injuring themselves. What do we know? What's the recommendation? That's the situation. What do we recommend? This patient maybe need to be, the room may need to be moved. This patient might need one of those beds that go really, really, really low to the floor. They may need mats. What is it? Because safety is a huge piece. Safety is a huge piece. So we want to consider that. Now, these two just looks at assertive versus aggressive. And they're, like I said, just pretty much the opposite. Assertive involves expressing ideas and opinions openly. while remaining respectful to others. Well, aggressive involves expressing ideas and opinions while violating their privacy, being disrespectful and rude. Okay. So these are just some negative interactions, coping mechanisms. The person may project onto the other because, they're not dealing with whatever the issue is. There might even be denial, but these are just coping mechanisms. And so we do want to address those just to ensure our clients are making, not that we're trying to make them do anything, but I just want to make sure people are making an informed decision, that they're not afraid of what they don't know and they don't understand. So they're just making a decision. So problem solving steps. Remember I mentioned early on about the conflict. Once you get people to write out statements and you hear what they're actually talking about, a lot of times they what they initially said the conflict was is really not the problem. So the problem solving steps include defining what is that problem. And that may come from getting statements, looking at logs. It may even require looking back at, people, facilities have ways for you to, be logged into their facility. Sometimes it's paper and pencil. Sometimes you have to show an ID. An ID has to be scanned. And sometimes getting those logs, for example, a person says, you know, someone came to my parents' room, mom's room at 2 p.m. and they removed her wallet or they removed the flowers that were in her room. And so the issue is they're saying that there's been theft at 2 p.m. on whatever day. It may take getting statements, looking at the time stamp when people clock in and out, and also the visitors log, whatever method it is, whether it's paper and pencil or getting the electronic record out. So seeing what that problem is, then deciding on, do we have all of the information? What's the goal of solving this problem? The issue is we want to clarify, that, we don't even have anyone coming in the facility between the hours of 2 and 4. We want to clear up that, we're not in on someone removing things from your mom's room. We're not aware of that. The choosing alternatives, that patient that said that they just signed off on whatever, they really didn't understand what the dietitian recommended, have that dietitian to come back in, or they just said yes, even though they know that those food choices are things that they don't like. Have that dietitian to come back in and see if there's some alternatives. Does the patient have to eat what that main meal is, or are there some more options to select? And then we want to try out whatever those alternatives are, evaluate whether they're effective. It's kind of like this care plan process, almost sort of kind of. And then repeat the process if the solution is not effective. So we start back over. What was really the problem? Well, I said, someone came into our mom's room and removed things, but it really was the two siblings were having an issue and they really wanted to know that the sibling come visit the mom. Just having that conversation. The patient, that is alert. Now I don't want to say allergic to, really don't like whatever those food options they have on the menu. So that's really the problem. Not that they don't want to eat, it's just that the options that are on their tray, they don't eat those things. So it's just a fluid process. You just have to keep going. Conflict is just part of it. You don't want to say conflict, but there are going to be issues or conflict. And that's what we're signing up to work through what those issues are, to have those conversations. So work-related issues. So patients, family members, they can, hopefully this doesn't happen, but assault is real. Workplace injuries, they can happen. You don't want to leave a facility without documenting and reporting if you've been injured, if you've been assaulted, if you've been verbally abused by a patient or family member. You want to make sure that all this information is documented. So manipulation, feelings and needs of others are disregarded, or other people are treated as objects to fulfill the needs of the manipulator. So, in the event that someone's having inappropriate talking to you inappropriately, you want to nip that in the bud, refuse to participate in those conversations, state that it is not wanted and is there, it is inappropriate, and document it and report it. Aggressive behavior in the workplace, such as instability, being rude, interpersonal issues, and hostile acts that are not obvious to others. It can result in job stress. A person might not even want to go to work because, they know that this person is working and they're saying things to them. They're being rude or they're saying things that are inappropriate. And so we do want to make sure that we report that. And when you do your onboard and you sit down for that interview, ask, what happens in the event that, who do I report to in the event that someone is, being verbally abusive to me, to my coworkers, what does that look like? So don't be afraid to ask that when you're doing your onboarding and deciding to work at a facility if you're having those interviews. Sexual harassment, of course, is unwanted, is an abuse of power. Most incidents are not reported. And so you do want to let that person know this is unwanted, it is not respectful. We want to, even if you have to call the authorities, and a lot of facilities, part of their policy is that you do notify so that everything is documented. So you have to call the police, that's what you do. So lateral violence occurs between nursing colleagues, people that are on the team. You want to make sure that you're following policies and procedures because sabotage is a real thing. Withholding information, backstabbing, nonverbal innuendos. Make sure that you are following whatever that policy procedure is. If it says that some facilities, for some medications, you need 2-person signature, and the nurse comes up and say, "Hey, I need your signature. I'm getting ready to administer this medicine. I've already administered the medicine." If you didn't see it being administered, don't sign your name off on it because the policy says that you need 2 persons to witness it. And so make sure, even if you're destroying medicine, some medicines, if you have to waste them. If and you all may have seen this in clinical where the dose that's being ordered and the amount that's in the vial or the what's the other little thing, the little container is more than what's needed. So you have to waste the other part. It requires a witness. So don't be signing off on things that you're not witnessing. And if a colleague is up to no good, then you may experience, some sabotage or things like that. So you want to make sure that you're not signing off on things that you're not supposed to, because they may come back and try to retaliate. Vertical violence occurs between persons of unequal power. The behavior humiliates and undermines confidence. The person who is bullied ends up feeling fearful and unsafe. Unfortunately, these things do occur, so make sure that you're reporting and keeping everything documented in the event that you are experiencing these things. Factors leading to workplace violence, personal factors, workplace practices, environmental factors. You just never know what a person is dealing with, and then how they're going to their steps to dealing with whatever it is. They may come to work and take it out on the coworker. So you want to make sure you're noticing some unusual behaviors, unwanted behaviors, inappropriate speech and talk and things like that. If we're not talking about these patients, we don't want to be careful with, even when we get, like I talked about, when we get in small groups, make sure that we're talking about what we're in there supposed to be talking about. Because, if you get to talking about other things to be misinterpreted or said that are inappropriate. And then, so what else? Early signs of workplace violence: angers easily, infrequent arguments, spreading gossip, cursing, increased irritability, and anxiety. These are early signs that something's more than likely going on. Then the next stage, conversations focus on poor me, the victim, notes with threats, violence, or sexual content, verbalization that includes plans or desire to harm someone. Unfortunately, these things do happen sometimes. Stealing workplace property, increased arguments. To prevent workplace violence, what do we need to do? Make a personal commitment to follow prevention guidelines and organizational trainings. When you're sitting down in that interview, ask, what does this facility do to prevent workplace violence? What are my steps in the event that this happened? What steps do I take? What's my response? Remember that the focus is on general self-defense, not offense. Prepare before workplace violence becomes an issue. So informing yourself, making yourself aware of what are those steps and what you do in the event that it does happen. You do want to be familiar with the workplace policies that covers violence as well as harassment. Be alert to those warning signs, like we talked about. What was it? Unusual behavior change, cursing. It's like, why is this behavior, why are we using, why are we cursing? And we're just doing shift change. I'm getting report. So those are cues and things that something is going on. Be alert to those warning signs and what you can do to prevent the escalation. You want to remove yourself from that situation. Take all threats seriously because you just never know. And so that's why, we don't play about things that are, that shouldn't be played about. We want to talk about taking care of this patient. Otherwise, goodbye, we're leaving shift and moving on. So report them to management. Encourage others to do the same. You do want to make note of it, if you're, and it's something, it could be it seems simple. If the facility wants you to park in a certain place, and those parks over there are closer. In the event that something happens, they have, I've noticed a lot of facilities, cameras are everywhere, but it seems like they have more cameras on where their staff parks at. And so if something happens, is more likely to catch it in that area. So sneaking and parking somewhere else, if something happens, then it might not even be recorded because we parked in the incorrect parking space. So I said all that to say, make sure that we're following the policies and procedures of our organizations because they're there to protect you and that patient. So organizations want and need organization growth and learning. They want to grow. They want their workers, the team members to be satisfied. They want their patients to be satisfied to keep coming back because organizations, for the most part, they're in business to provide services for the people. And they do get those reimbursements. If patients stop coming because they're not satisfied, then that organization actually does not grow. That organization might have to even shut down. And so organizations, they want and need organizational growth. So when you're on the ethics committee, go back to the different theories, go back to the evidence-based information. What do you recommend? Don't be afraid to make those recommendations because what they're going to want to do is revise policies and procedures that are safe for the person, the team members and everything. They want that growth. They encourage that learning. Okay, are there any questions about those slides? Okay, I'm not seeing any questions in the chat. And we're gonna move right along. We have one more, then we'll do another case study. So now we're getting ready to talk about the people on the healthcare team. There are so many of us, and everyone is just as important as the other. So let me share here. All of us are needed, but what happens is you're the nurse, gonna be right there in the middle. They're gonna come to you wanting the answer. What should they do? What should they do? I mean, even though we have everybody and they know what they know, they come to that nurse. You're that person in that middle. And they look to you for that guidance. So we have a group of professionals who contribute to the care and treatment of the client. The example that I gave early on, the physical therapy coming to the room to provide the physical therapy for the patient needing to go for their follow-up appointment. All of that's important. And we don't want to stop this person from getting all the care that they need so they can go on and manage their care or get to their optimal level of care. So work together to meet common objectives. So what does a case manager do?
It assess the needs of the patient, leaving home, like for a patient who just had a baby, they may find resources for her to have a car seat. For a patient who had an amputation, they may have resources for that patient to have a ramp up, something like that.
Okay, yeah. So that discharge planning. So that patient, because they're in the hospital, even if they're in that long-term care facility for that therapy, they're not there forever. So they're getting ready to go home. that case manager puts together and thinks through, because we know that discharge planning actually starts on admission. Even though it might change, we start talking about what is this patient going to need. Patient that's going to give birth, so we know that the child's going to need a car seat. This patient had surgery, they're going back home to get their therapy at home. We got to set that up. What time? So coordinating all of that discharge planning, no matter whether or not they go home, they're going to need home health, or if they go to that long-term care facility. So tell me, what does a dietitian, what do you think in overall, what do they do, dietitian?
They make sure your food is correct, whatever type of diet you need.
All things nutrition. So the type of diet, enough calories, the consistency. For example, this person has a problem with swallowing. They need their liquids thickened. They need nectar thickened liquids. They might need honey thickened liquids. I don't know if you all have seen those different consistency of those liquids. They may need supplements in between meals. They may need additional portions during mealtime because they have a disease process where they're needing more calories. So all things nutrition.
They also make sure that they have access to healthy foods and resources to find places that like do not Meals on Wheels, but do the food drives that give out fresh fruits and stuff like that.
All things nutrition. So they work together to meet that common objective, which is for this client to get the best care so that they can manage and be at that optimal level. Or if not at that optimal level, as close to that optimal level as possible, prior to coming into a facility. So that care coordination, like we mentioned early on, is recognized as a professional standard. It is essential for that client not having those repeated readmissions. It is necessary to improve that quality of care that client is receiving. It is necessary so that client can manage their own care. Care coordination organizes care and information around patients' needs and their preferences. Like the client I was just talking about, they were not eating, they're documenting 0% for meals. The client just simply doesn't like what they're being offered at mealtime. Not that they don't want to eat. So we need to consider what that client preferences are. But we do want to keep in mind that this client needs so many calories, the food needs to be a certain consistency, and so forth and so forth. So we have Virginia Henderson. She refers to nurses' interest in illness and wellness. So we have a bunch of theorists out there. Now, she stated the unique function of the nurse is to assist the individual, sick or well, in the performance of those activities that contribute to their health or their recovery. And if it does include having a peaceful death. We do, when a person, we don't know when someone's going to pass away, but if signs are that death is pretty much imminent, we want to make sure that we preserve their dignity, that we're providing that mouth care, doing that turn and reposition, or whatever those interventions are. So it's everything to assist that client, sick or well, so that they can be at their best, their optimal level. And like I said, she just narrows it down to her interest refers to illness and wellness, sick or well. If you just want to narrow it down, her theory, where her theory was focused on. We talked about collaboration. Effective collaboration involves sharing observations and inviting input from other disciplines to optimize the client outcomes. So I keep talking about that physical therapy. So the physical therapist comes to the room to get the patient to take them. Usually they take them down to a therapy room or area that's used for therapy. That nurse, we want to ask, well, how did that patient do? We want to read those notes because sometimes those clients, those patients, we'll see a whole different side of them. The physical therapists will know, well, hey, this patient was talkative. They were involved in their care. And then in the room, they're resistant, or the opposite, it could go either way. But we do want to invite that input, ask, how did they do in therapy? Were there any barriers? Is there anything that we can do to optimize this client's outcomes? And then the other example I gave where the client was refusing to go to therapy, and then we found out the client was hurting. They were in pain. And we know that therapy requires that movement, that motion, because we're trying to get them back in the swing of things. And so having that output, but the client said that they don't want to go because they're, the pain is just so bad. But we'll notify the healthcare provider. More than likely, they're going to order them something so that that pain is lessened. They might not be pain free, but it's lessened so that they can get that therapy. Because remember, the bigger picture is we want them to, where was it on this slide? For them to get back to their optimal level so that they can manage and be at their optimal level. Okay, so we kind of talked about this. We talked about the case manager. Now, what about the social worker? Are they kind of the same? The case manager and the social worker, sometimes do their tasks sometimes overlap or kind
Yes.
of the same? So yes.
Yes.
So nevertheless, they do now. The nurse case manager, we have that nursing spin on it, and that social work. But some of the tasks that they focus on, and like who was it just mentioned? Not the Meals on Wheels, but getting the fresh fruits and vegetables. They may know they can identify that social work some other resources that are out there. But nevertheless, we're gonna all be working together. What will let's see, let's look this. The dietitian, we talked about that one. What about the speech therapists or the speech language pathologists? What do they do?
They help them with, I guess having problems swallowing or,
Like swallow test.
yeah,
Or
or even not just swallowing, they also help them. Like if their sounding is not right, correct, they'll help them to how to use their vocal a way where it'll sound like a S or a T, you
Yeah,
know,
like,
or
like when
like a
they have
stroke
sometimes when
patient.
people have strokes and they have to like recover, sometimes that'll so they can be able to verbally explain simple things. It don't have to be a full sentence, but at least be able to get at least 5 to 10 words.
So all things speech and swallowing, diagnosing, like they're the same ones that would do like the person we think this person, for example, signs and symptoms. We the unlicensed personnel report this client coughs when they're drinking milk, they cough, they're drooling. The patient had a stroke, and we know that they may have problems with expressing themselves. So they diagnose and treat, give those recommendations for speech and swallowing disorders. And that's a chronic disorder is a stroke. A lot of times that does affect people's speech. So yes. So what about we talked about the physical therapy and the OT? What are their main tasks?
um daily I guess their daily living, teaching them, how to go back and learn how to do it. If they did have a stroke or had some type of surgery where they forgot how to do it, they'll teach them how to, learn step by step.
Like try to help them to get back to their baseline as close to their baseline
Hmm.
before.
All things mobility, movement,
Yeah.
activities of daily living. Like I said, think about what it takes to open a refrigerator. Think about what it takes to open a gallon of milk. Think about what it takes to
But
stir the soup in the pot.
mm-hmm.
What does it take to walk up the steps? To open that car door, to fold the towel. So all things mobility. Think about all those activities that we do daily, but we really don't really think about it. So what about respiratory? What do they do?
The lawns, they
All things
assess
with
the
breathing.
lawns.
Yeah, all things with breathing.
Yeah. Hmm.
Yes, all those breathing issues. Um, so all those different respiratory diseases, asthma, COPD, all those breathing, all things from respiratory or breathing. Okay. So what about the radiologist?
They read your they get to do the test results, like read your test results, and
Now, which one do they do? Say that again, Miss Murphy.
they read your test results. No, they like
They do
perform the
your
test results.
results.
Okay, well, let me ask you this question. Which what does the X-ray tech do versus the radiologist?
The radiologist diagnoses it. The X-ray tech like does the X-ray, the physical X-ray.
Exactly. So the radiologist is not the person that's going to come out and actually do the
Right.
X-rays and gather the
Hmm.
information. The X-ray technician does that. The radiology is the person that actually reads the X-rays. Good.
Yeah.
So what about the pharmacist?
Medication.
Okay.
Medications.
They prepare them. They even compound them. Some medications that, yeah, and that think about blood pressure medicine, antihypertensives. They're kind of putting a lot of those medications together, which they call it compounding. So they're the ones that prepare, even if a medication requires to be compounded. They dispense those medications. So what about a surgeon?
They do surgery.
Surgery. And they're more than likely going to be the person too that's going to prescribe that person some pain medication too if they need it, especially if they're right, if they've actually done surgery. They're the ones that come in and oversee that pain medication. Even though that person will have that primary healthcare provider, that surgeon, if they've done surgery, they come in and they say what to do with that. Okay. And there's so many others. Oh, there's lab personnel. What do they do?
They draw blood and they run tests.
Okay. And there are different levels to the lab personnel. We have all of them
Yes.
more than likely can draw the blood. There even have some that's often there that can run certain tests, and some that call you the test results or upload the test results. And so yes, but all of us, all these people and more are needed. And it's just as important as the other. Healthcare workers of the same discipline that work together to integrate care that will provide clients with all services they need to maintain safety, you all can't say safety enough, quality, comprehensive healthcare. There are different levels of education. Like we just said, the person that's the x-ray technician, they're the ones that go out and gather the x-rays and those film. Not to say the radiologists can't, but their main primary goal is to read and interpret what they see on those film. Each member of the healthcare team needs to have that good communication skill. Each team member has to be able to anticipate problems to avoid them when possible. A lot of times when that x-ray technician comes in, they'll come get the nurse. Hey, I need some assistance with maybe, for example, if the person needs two persons assistance with turning requisition, they'll come get the nurse to help assist with turning, and or to come and help explain, what they're getting ready to do. Because a lot of times, if a person has altered mental status or may have some confusion and they see a stranger comes in, even though that person has explained, I'm here, hi, I'm Joe, I'm here to do your x-ray, to take these pictures, they may still need you to come in and help facilitate the message that's being sent so that x-ray can be done. But nevertheless, no matter what the role is, we're all important on the healthcare team. This is just showing all the different levels. And within, you can get certifications. Some facilities offer certifications within those facilities, and you can't transfer them out. In some, you can, but there's so many different avenues and things you can do as a nurse. This one is just showing the role of the registered nurse. Okay. And then for the LPN, we go in and we can gather that information, that assessment phase. The RN doesn't need to be there with us to gather that information. They don't need to be there with us to, administer our medications, to do dressing change. They can be, but we can do those things independently. And remember our Nurse Practice Act. That's our lawful to-do list. These are the things that we can do lawfully within that state. And remember, sometimes your coworkers will ask you to do things that they know you're not supposed to. But it's going to be on you to know what you can lawfully do and to say, nope, can't do that. So we provide care to clients under the general supervision of the registered nurse, the doctor, the podiatrist, in long-term care facilities. For the most part, a lot of the podiatrists and the dentists, they come in and they render those services in that facility. So we as the LPN, we can coordinate that care, getting those people to that designated area. Now there's sometimes depends on what's going on with the patient or the resident, the foot doctor may go to that patient's room, but for the most part, we have to get those patients to that designated place because they set, and I don't know if you all have seen this in the long-term care facilities, they set that designated space up just like they're in the dentist's office, just like they're in the foot doctor's office. And you all have seen that. We just got to get in. They see a lot of people in that amount of time. So we have to assist with getting those patients to and from, because the patients, even though that they're in those long-term care facilities, they still receive those same preventative services as though the eye doctor, they come in as though now things like mammograms and things like that, of course, they'll have to go out for that. But X-rays and things, they can do that at the bedside. Okay, so nursing roles and role difference between the case manager, the care manager. So you're going to be that first line manager in those long-term care facilities, you all. They're going to be coming to you because we can be that first line manager, especially day shift for the most part, no matter where you're at, there's plenty of people around. But as the day goes along, there's less and less people there. And they're going to look for you if that fire alarm goes off or we need to pull the fire alarm. In the event that there's inclement weather coming, what do we do? What they'll be looking for you to guide them as to what their next steps are. It's not that they don't know what to do, but you're just that centerpiece, and they just look to you to assist with reminding them and providing that guidance. So here, who does what? Identifies possible new nursing problems and reports same to the RN. Who initiates all phases of the nursing process? Who works with established nursing diagnosis? And who formulates those nursing diagnoses? Okay. All right. And so I think this is the same slide we just saw. Okay. So we kind of already talked about this, the expanded role of the LPN or LVN. You're that charge. You can have that charge position at that long-term care facility, not an acute care facility, but at a long-term care facility. Consults with available registered nurses. As the day goes along, there are some facilities that have registered nurses on site, but some they don't. People are on call. The ADON may be on call, the DON may be on call, but who's there as the day go along? It might just be, us that LPN. And then we're there to assist with care coordination. Patients went out for a procedure and something happened at that facility and they were running late. So the patient gets back. Everybody gone home. It's up to us to look at those orders and to reach out to clarify orders in the event that the order needs clarifying. If there's something questionable about that, we're going to talk about delegation, all of that, not next week, but later on in the term. But we assign and supervise the unlicensed personnel. We're that main piece. So we do have what we call total patient care. Usually you see this in the ICUs, and that means that person needs to be fed, that person needs to be bathed, that total patient care is given by that nurse. And then we have the functional nursing assigned to complete certain tasks rather than care for a specific patient. So, if you have that specific, like I just mentioned, in some facilities, I think insertion of the G tube, not the initial one, not the peg tube, but a person has that G tube that has to be changed out every so often. Facilities usually will in-house train someone or certify someone, and then you'll be called on in the event that tube needs to be changed. You see this a lot with wound care within long-term care facilities. They'll give you that extra training, and then you'll be that wound care nurse within that facility. That's what you specifically do for the patients. Team nursing, assignments according to capabilities, collaborate in providing care to a group of patients under the direction of the RN. So we're on this, we're providing care to everyone. We're not assigned just to this group of people, but then each nurse is assigned different tasks. The primary nurse assumes 24-hour responsibility for planning the care of one or more patients from admission to discharge. And then the care management or case management, care coordination within a specified time frame using those clinical pathways, and they help the patients assess those community resources, which you all just said, learn medication regimens. They may have to even identify pharmacies, because if they were not on medications, they have to identify a pharmacy. And if that person needs medications delivered, then certain pharmacies deliver, some don't. They will have to help, identify all those moving parts so this client can manage their care. That is the same information. So client-centered relationship, centered care philosophy Providing care that is respectful of and responsive to individual client preferences. You want to find out, what do they value? What's important to them? We can come up with all these nice interventions, but if what they value and their goals for their care is different than what we have, then more than likely that client's gonna be non-compliant. So that's why we want to establish these therapeutic relationships and ask, what do they understand about their disease process? What do they understand about how to manage this disease process? As healthcare workers, sometimes we just take for granted everybody knows what the blood pressure numbers mean, how to do the finger stick and what that means. And so we want to verify what they know. And then what goals have they set for themselves? Because it's them that's receiving the care, right? And so we want to get their input in on it. Okay. Discuss continuity of care. We talked about care coordination. So in the chat, we're going to utilize the chat again. Just do a one-liner. We'll give you 2 minutes. Continuity of care. What does that mean? Continuity of care. Let me get to my little timer here. Continuity of care. If we were discussing it or giving health a one topic or a speech about it, what would we tell someone that continuity of care is? What are all the moving parts? What does that mean for a patient? I know a minute, at least 30 seconds done went by you all. So I'm gonna put my timer on for a minute and 30 seconds. Trying to get into my phone here. Okay, let's see and start. Okay, let me stop sharing so I can see what you all are putting in the chat. Continuity of care. What is 54 seconds left. Continuity of care. Fourteen seconds. Okay, I'm gonna go ahead and start reading out what you have here. Continuing care. Okay. Thinking about all the stages of treatment instead of fragmented or one-off visits. Care is coordinated. So our time is up. So the patient's history, needs, and goals are always known and considered. Ongoing. Patient informed and educated at every step. Stays connected. And someone put in here consistency even when changing facilities. So if a patient is being transferred, they're being discharged to a long-term care facility, or if they're being transferred because the status has changed, or so a lot of times, sometimes you'll see it in the hospitals where, that person, they may need, you know, specialty care and a specialty is not there. So they're being transferred to another facility that has accepted them. So making sure that they know all this information that we know so that care can be provided. Good, good, good. Because otherwise, if we don't, there can be that disconnect with that client care. If this client is going home, they're getting home health. Home health doesn't even know that this patient is going to need a concentrator or oxygen cylinder, however method that they need this oxygen. This client's not going to have their oxygen when they get home. If the example that I just talked about, the pharmacy where this client is not going to be able to get to the pharmacy, they need a pharmacy that actually delivers. If this pharmacy that they usually use don't deliver and they don't have anyone to go get their medication, how are they going to get their medicine? So that continuity of care, it's really, really important. That patient is changing facilities. If that information, whether they're being discharged or going to another facility to get that level of care that they need, this client having that continuity of care and everything being communicated, it decreases or reduces the risk of hospital readmissions. The patient is being discharged and they do understand their discharge instructions. They know that they're supposed to do the finger sticks. They understand that sliding scale. If they understand they're supposed to call and make an appointment to follow back up in 6 weeks or whatever it is, that decreases the chances of this client coming back to the hospital and having unwanted health outcomes, negative health outcomes. That continuity of care. It ensures proper follow-up, medication management. They understand that BID means twice a day. Take it in the morning or the evening or however it's prescribed. And coordination between care providers. This patient the care is being transitioned to hospice care. That hospice provider knows that this client, needs a hospital bed or requires total assistance with baths. That coordination between care providers, it is needed in order for this client to have the best outcomes that they possibly can have. Patients are more likely to maintain their health, avoid complications that could lead to rehospitalizations. It's rare that people don't want to take care of themselves. It's them understanding what they need to do in order to manage that disease process. And then having the things that they need in order to do that. The example, well, I can't get to the pharmacy, but I need a pharmacy that can deliver. Or that social worker identifies a resource that can get that medication delivered. That continuity of care. And it does require all of the healthcare team. So each member of the interprofessional healthcare team provides a valuable service to the client. All members of the healthcare team are equal in importance to each other. We've been saying that. They're going to come to you, that nurse. It's like, okay, well, don't you know, but you're that nurse. They coming to you. To understand where the licensed practical nurse fits into the interprofessional healthcare team, be aware of educational background, roles and responsibilities, and possible licensure requirements. Remember what's on your to-do list, your lawful to-do list. Our state nurse practice act says we can do what we can do. Those other things that we're being asked to do that's not there, you speak up for yourself and say, hey, nope, can't do it. The Institutes of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual client preferences. What is this client? What's their goals? What do they understand? What they need and value? Ensuring that the client's values guide all clinical decisions. Ineffective communication is the primary cause of sentinel events, making patient safety the primary objective of handoff communication process. So we want to make sure our communication is effective, not ineffective. Make sure that we're actually sharing information that is clear and understandable. Okay, the only thing we have left is our case study. We're almost there to our next rate. We're going to go ahead and just open up the case study and start looking at it. We might have enough time to get in our groups. You may have enough time for the case study and a little time for our groups. Let's see, let me find it here. Okay, so we're just gonna do some, just on that paper, just do some jot noting. I'm gonna let you read the scenario and just jot down things that just pop up that you think are of importance. I'm gonna share my screen here. Okay. Busy medical surgical unit. So think about the environment. Are we at home? Are we in a long-term care facility? Are we in the urgent care? Or we're in an acute care setting? If they're on med surg, that's an acute care setting. So our mind automatically starts shifting to acute care setting. Some things, should start, we should push them to the side, and some things we should start focusing on. Okay. So we'll just we have 4 minutes. So we'll give you this 4 minutes to read through this, do some jot noting. Just whatever comes to mind. I don't want to guide you. I don't want to focus you in on any one thing. So we'll do the 3 minutes, just reading through and do some jot noting here. Okay. So as you were reading through the scenario, we're thinking about where is this patient at? We already said acute care setting. Anything in this first line that we need to consider?
The age.
The age, exactly. Remember, that slide was considered whether or not we were talking to the child, the adult, the older adult. So the age, one said the age.
And that
Anything in this? Go ahead.
that he has anxiety as well.
So what about this second
And
line?
this
Patient
and
admitted with
Yeah, I
pneumonia.
made it for pneumonia.
Pneumonia. So our mind should be
COPD.
going to what is pneumonia? What body system is mostly affected when someone has pneumonia? What are those assessment things that I'm going to do as a nurse to be assessing that body system? So what body system does pneumonia mostly have to deal with?
With the lungs.
Or like the lungs.
So the respiratory system, and those
Mhm.
organs are the lungs. So what things do we do to assess the lungs? What do we do?
Listen to them.
Listen to
Listen to
them.
the breath sounds.
Okay. What else?
If we have to put them on oxygen.
Wait a minute. Listen to the question. What things do we have to do? What things do we do to assess the respiratory
Oh,
system, to assess
assess.
the lungs?
You can also take
Also say that
also
Mm-hmm.
So we listen to the lungs. What else do we do, you all, to assess the respiratory
OSAT,
system?
the OSAT monitor.
O2.
too.
What
Yeah.
else do we do?
Post.
We count the respirations, right?
Mm-hmm. Yeah.
Okay, we count the respiration. Got O2 set. We may even do cat refill, can be heart and respiratory. Okay, and so we want to pause here. We're gonna try to stay on time. We're gonna stop and do our 5 minute break here. So let's return. What time is it? 7:31 at your time. So let's return at 7:36. See it in 7:36. Okay. So we said those things that we would do to assess here. Okay. So now this third line, anything that we need to make note of here?
Anxiety.
That she gets frustrated with repeated questions and
We right here on this line, right here.
oh, I'm sorry. Oh, COP and anxiety.
COPD and anxiety. Why
Mhm.
is COPD significant? Why do we need to know about that?
Because
Patients
you
is
know that causes
already
anxiety.
already compromised.
Exactly. He already has
Beyond
something going on with the respiratory system. Not only does he have problems with gas exchange, he has another, it's like a double whammy. He also has pneumonia, which is another disease process that further can compromise that gas exchange. Okay. And then he has anxiety. I don't know if you've ever got choked or coughed or got strangled or something went down the wrong way and you had to cough and you got a little anxious, right? So this person already has anxiety. They already have a problem with gas exchange. Now they have pneumonia. So if they already have anxiety, they might be what? More anxious, right? If they already have anxiety. So these are things as we're reading through scenarios, we're just taking each piece and see and thinking it through. Okay. Now, he frequently asks questions about his care. Is this because he's just trying to ask questions or
He said he has anxiety about it, you know, about the situation.
exactly? He's having problems with gas exchange. I don't know if you ever been short of breath before or got
yeah.
that was not a nice feeling, right? And so, yes, I need to be knowing about what you're doing. And then he often uses the call out. The other piece of that is if people are frequently asking questions, they may just want to be aware. What about we just talked about communication. What about if the sender, I'm the nurse, the information that I am responding, I'm sending to him that I'm stating that I'm saying is not being interpreted correctly? What if what I'm saying makes no sense to him? Is that could that be why this person's asking frequent questions?
Yes.
Or is it because okay, we're gonna get to that part. I want to get ahead of myself because I think it's down here. Okay, so doing a particular busy shift. So time management, we gotta manage ourselves because we don't have time to be talking about all that other stuff because we have these patients that we're supposed to be taking care of. It can get busy. If one client or patient changes, if their status changes, whew, things can get really, really busy. So the nurse becomes frustrated. So once that nurse becomes frustrated, does the nurse not have an outlet? What should this nurse be thinking about if they're becoming frustrated? They have a busy shift.
Yeah.
What was
Maybe
that?
go to their supervisor and
Exactly.
you
Seek
know,
out help.
yeah.
Even though that you're that nurse for that person, there's still someone else there that can assist you. Don't be afraid to call in for assistance. But if you don't, our response might be what her response was. Okay, so when Mr. Reynolds asked for clarification about his medications, so this person, they're asking questions about their care. They're having problems with gas exchange already. They have anxiety. They have a diagnosis of pneumonia. They're probably having even more of a challenge with gas exchange. They are asking questions. So they either are informed and want to be better informed or more informed, or just want to be aware because we just said consider the client preferences, consider what they know. Ask, what do you know about this process? What are your goals? So when Mr. Reynolds asked for clarification about his medications, George responds in a rushed and dismissive tone. I've already told you what they're for. You need to relax and stop worrying. So, okay, Jordan goes in the room and she's answering the call light, and he asks for clarification. You're that nurse. You know this person has something going on already, a chronic disease process that's altering gas exchange, has pneumonia that's further compromising him. What are some things that we need to be assessing as we go in just to make sure that this client isn't getting any worse? What did you all just say?
Mental status.
Yeah, yep.
What else?
His vital signs,
What else?
his
Inspiration.
Counting those
you know,
respirations.
yeah, but that's vital
Determining
signs.
how is he speaking. Is this person completing sentences without problems, or are they having problems completing sentences? Because if a person has problems completing sentences, and I'm not talking about they're stuttering, but if they're truly having to stop to catch a breath, that more than likely means that they're having problems with gas exchange. So as a nurse is going in, I know she's frustrated, but this person is going in. So we can do those little reassessments. And if we do see that this person is having problems with counting their respirations, we can even reassess what the O2 stat is. We can reassess. And then if they're using accessory muscles, the other part of that is we said he's asking for clarification. So, Mr. Reynolds, I informed you of what the medication was for. What's wrong with me restating it? Was it not clear? Was this a new medication? Did you understand what the information that I gave you? Do I need to tell you more about it? Do we need to get the printout from pharmacy? Because it's more than likely this person is just not ringing the bell just because he's ringing the bell. This person may be getting to the point where, like the other scenario, that person was actually having chest pain and their conditioning was becoming more unstable, or
You're
this
right.
person,
Right.
or this person just really don't understand. Go ahead, Ms. Murphy.
I was just saying about what you were saying. Yeah, it could be that as well. And also, maybe the medication they are getting, maybe they feel like it's not working.
Exactly. So we're doing those spot checks while we're in there talking to them. We could be looking at those respirations. Are they having trouble breathing? Because it could be that this person, you gave me this medicine, but I'm still struggling with my breath, even though there might not outright be saying that, but our mind should be going back to, let me reassess this person. Why do they keep ringing? Are they just ringing just to be ringing? More than likely not. Something's more than likely going on with this person. Medications might not be working. And then the name that we're saying, they might not be accustomed to it, because they have a generic name, trade names, and this person might want to verify, well, hey, at home, my home meds include this, this, and this. And you said this, and it could be that this person maybe just trying to clarify this medication you're giving me, I may have an allergy to it. Now, what you say you gave me, just trying to make sure. So it's rare that this person just ringing the bell just to be ringing the bell, just to be doing something.
And also, couldn't it be because they may be afraid, of the situation? And even as the nurse, we have to have that compassionate part about us, first. That is a part of our job to make sure that we can, help them with those fears and different things like that. And
Exactly. Even if it means bringing that team leader in to assist with whatever's going on with this patient, so we can spend a little bit more time with them, so we can gain some clarity. They can get some clarity, or if someone else is has went bad or become unstable, calling that. If we need help, ask for help. Don't be afraid to ask for help. Okay, here we go. Call light pressed again. Later, when Mr. Reynolds presses the call light again for shortness of breath, Jordan delays responding, assuming the patient is being overly anxious. This time, he's pressed the call light, and he really is short of breath. When Jordan finally enters the room, Mr. Reynolds appears visibly distressed with increased respiratory rate and decreased oxygen saturation. The RN is notified and the rapid interventions are initiated. Like we just said, that medication, it could have been that the person was allergic to it. It could have been that this medication wasn't his home meds or what he traditionally had been on, because for the most part, they try to keep people on the medicines that they know have been working for them. And so we need to have found clarity is what was going on, is why he was really pushing the call. Like now he's short of breath, but then the nurse, they're delaying in our response because we're thinking he's just pushing the bell. Okay. All right. Mr. Reynolds requires escalation of care, including increased oxygen support. Okay. He expresses fear and distrust toward the nursing staff. Do you think that is a valid fear and distrust? Is that valid from Mr.
Absolutely.
Reynolds' part?
Absolutely.
Yes, absolutely.
Exactly. And even if she has to say, Mr. Reynolds, and I've answered your questions to the best of my ability. Let me get someone else in that can help you, even if that would have been the conversation. Then that distrust might, would have been lessened. He later responds. He later reports feeling ignored and talked down to in a patient satisfaction survey. Remember, I told you they're gonna always. We don't know that this is going on, but there's someone that comes back and asks these questions, whether or not they mail it to them, they do it on site, electronic, or paper and pencil. That's part of a facility's growth plan. They need to know what the patient has thought. So at this point, okay, then the incident is reviewed by the nurse manager due to concerns about delayed response and communication style. At this point, who else is going to probably be involved?
The physician
And
Yep.
who else?
The family.
and the RN,
And who else?
The
Discipline,
disciplinary team.
respiratory,
Who's going to be their disciplinary team? So yes, respiratory, the doctor. Who's going to be part of that disciplinary team?
nursing education, because she didn't Jordan didn't reassure, didn't re-educate, didn't ask, didn't reassess. So that's a teaching moment.
Okay.
And possibly the ombudsman.
And who else? You think
Even
this
from the
might be his lawyer.
exactly? And who
yeah.
else?
DHEC.
Who is that, Ms. Murphy?
Yes.
DHEC maybe.
And who else?
The ombudsman. I don't know.
The board of nursing.
No, the board
Jordan
of
has
nursing.
put
Yeah.
her license
Forgot about
at
that.
risk.
Yeah, right. Yeah.
She's put her license at risk. So in the
Uh-huh.
event that you need help, don't be afraid to ask for help, because it may be the difference in the nurse keeping their license or not, the nurse being put on suspension or not, because it depends on the situation. Where was there a duty? Did Jordan have a duty? Did she breach her duty?
That's terrible.
Exactly. Mr. Reynolds, they had to call in the team, they had to put him on oxygen. Was that a direct cause of Jordan breaching her duty of not answering that call in a timely manner?
Yes.
More than likely it was. So that equals negligence. That equals abuse. 1-800 lawyer, 1-800 call the board of nursing, all of that. So don't be afraid to call for assistance, ask for help if you need it. Go back to your founding, your assessment, like how we broke it down. We looked at his age. We consider, what do we do to assess the respiratory system? Think about all those things. And you could just, while she's in there talking to him, you can look at the respiration. Is this person struggling for breath? So what are some key issues identified? What else do you think about the situation that we have not already seen? What else comes to mind?
She didn't ask the patient, what is the best way that you learn, so that she could educate him
All right.
and reassure him.
Okay. What else? What else? So the way we broke that scenario down, you all, we selected all that apply. You know how you have those questions? You got to select all that apply. That's how you sift through. Even if you have to go back to that body system, like how we said COPD and pneumonia, that's mostly with the respiratory system, and you identified what does the respiratory system supposed to do for us, gas exchange, what organs are a part of that respiratory system, how can we assess that? That thing that we just did, that helps you to select all that apply, because it helps you think through everything from A to Z about that person, about that scenario. Of course, you would have did a little bit faster if you were doing it on your own, but that's a testing technique there. So use of dismissive and non-therapeutic communication. I think we identified that. Failure to actively listening to the patient concerns, assumptions about the patient behavior, labeling this person as they're just a freaking, pusher, they're anxious, delay in, even though the person did have the diagnosis of anxiety, his anxiety was warranted. Um, Delay in responding to a potentially serious symptom, breakdown in trust between patient and the nurse, just dissolving that therapeutic relationships. Okay, so select one question and in the chat, put the number in your response. So we'll give you 2 minutes to do that. Just select one of the questions because our time is going to run out, and just do a response. So for example, if you select number 1, just put 1 and whatever your response is to that. Put 2 minutes on the timer here. If you select number 5, just put the number 5 and type in what your response is. Stop sharing here and start looking at your responses here. So we use this technique, you all, a lot. We respond verbally because we all do have different learning styles. Then I ask you all to use the chat sometimes, and that, or even though we've talked about all those questions, that gives you an opportunity to make sure that you're understanding what you understood about what we discussed. So there's a method to it. Okay, so let's look back here. I need to put both of them up here so I can see both. Is it this one? Oh, yeah. Okay, so what specific communication behaviors did Jordan demonstrate that were ineffective or inappropriate? So we said she assumed, she didn't listen to the patient's concerns. She just assumed because he had anxiety that he just wanted to punch the bell, just push the bell. How did Jordan's communication impact the patient's outcomes? So did I have anyone to answer number 2? Number 2. So her actions, they negatively. Oh, going back to number 1, someone said that she used aggressive communication. Good. So using those terms, that communication was not assertive. Good. It was aggressive. Good, good, good. What cues did Mr. Reynolds exhibit that were overlooked? Okay, what did we say? That's our little timer. Number 3. No one. Okay, we pretty much answered that when we said that he kept ringing the light, wasn't really sure if he didn't understand what was being communicated. Number 4, what should the LPN have done differently when the patient used the call light repeatedly? You all said make sure all questions and concerns were answered correctly in a way the patient could understand. Okay, listen to these concerns, explain things in a different way. Because sometimes that's why I'll state stuff, or I ask you all to state things or respond, then I'll come back and say things. Because if we say it in different ways, then more than likely it's gonna resonate and stick with you. If you hear repetitively and you hear it differently, but we're not changing it up. So that's good. Let's see, number 4 to number 5. how can negative communication contribute to the safety risk? So we said it can cause harm to the patient. Patient will neglect to follow the order you give. They will feel like they will just handle it on their own. Negative communication can increase safety risk. Safety, you all don't forget safety, because it confuses the patients, make them feel ignored or uncomfortable. It may not want to speak up and could lead to mistakes. It can lead to poor patient outcomes. Great, great, great. So what do we do if we have called the doctor? The lab technician has called and said, hey, patient in room 201 has, an increased white count. We've notified the healthcare provider via however we're supposed to contact them, whether it's pager, we call, leave a message for them to call us back, and they don't return the call. What do we do?
You got it.
Or reach out to your supervisor.
Okay. It doesn't stop with you, just like with this patient. It doesn't stop with you. So what if, and I asked this early on too, what if the patient signed off on a consent, we're getting ready to put them in the elevator, take them down for surgery, they change their mind? What do we do?
Stop.
His physician
Okay, stop.
or the RN.
Or the team leader. We just don't take them on down. You signed that paper. No, no, no. They have the right to change their mind. What about if we see an order that has a unusually high dose or unusually low dose, or if we're administering a medication, for example, antihypertensive, and we gave it at this hour, the next hour we see the blood pressure is not improving. In fact, the blood pressure is actually increasing. What do we need to do?
Call the doctor, get clarification.
Verification, call the doctor, notify them of that. Okay. So we do have our last 15-minute break. And so we've covered all of our content for this week. Just as soon as this video downloads and I upload it, I'll share it with you all. You all take care and we'll see you next week.
Thank you.
You're
Thank you.
welcome. Take
Bye-bye.
care. Bye-bye.